This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Tesha Monteith with the Neurology podcast. We're here to talk to you today about spontaneous intracranial hypotension. We spent a lot of time talking about more common types of headaches, such as migraine, but it's really important to discuss SIH because it's a condition that is often misdiagnosed and is often associated with a long diagnostic delay. With me to discuss is Wouter Schievink. He's a professor of neurosurgery and director of microvascular neurosurgery program at Cedars-Sinai in Los Angeles, California. This is a rare condition. How did you collect all of these cases and how were you able to contribute this much to the field?
You're right. I have seen a lot of patients with this. I'm glad that you mentioned that it's rare because it's really not that rare. Right? It's about 5 per 100,000 people per year will get a spontaneous spinal CSF leak. And that's not insignificant, right? That means that just in Los Angeles, which has 10 million people, there are 500 new patients every year. So that's quite a big number. It's more common than, let's say, idiopathic intracranial hypertension. It's probably more common than trigeminal neuralgia. And we think that these incidence numbers are grossly underrepresenting the true incidence because it is, as you mentioned, oftentimes not diagnosed. So it's really not a rare condition.
So what are some good clinical pearls in getting this diagnosis?
I think there are many clinical pearls. The headache is not always orthostatic. Another common misconception, and we call it hypotension, is that spinal fluid pressure should be low. That's actually not the case either, and we've known that since the 1990s. Many patients who have this have a completely normal opening pressure, or sometimes even abnormally high. We try to avoid a lumbar puncture if at all possible, because of course a much more common cause for low pressure or low volume CSF disorders is a lumbar puncture. So here where I work in Los Angeles, we have not used regular CT myelograms for at least 15 years. We use a technique that's called MR myelography, which is not where you introduce gadolinium intrathecally into the spinal fluid, but it's a heavily T2-weighted MRI sequence. And if anything, that's better than just a regular CT myelogram. And you avoid a lumbar puncture, you avoid radiation, et cetera, et cetera. Of course, when you're a neurologist and you see a patient with, for example, positional headaches or headaches in general, you have to think about the possibility of SIH if there is some type of positional component. And there are different tests that have been developed, like lying flat for 48 hours. I think that's somewhat of a cumbersome test. So I always ask my patients, how do you feel when you wake up in the morning before you get out of bed? And 9 out of 10 patients will say that either they will have no headache or that their headache is much lessened after they've been sleeping all night long. And of course, it's really rare for these headaches to wake a patient up in the middle of the night.
Yeah, and I know of cases where patients have been diagnosed with frontotemporal dementia, cases of coma. What has been your most surprising case or kind of interesting case to really have neurologists remember that this can present, as you say, more than a postural headache?
So, for example, coma. I remember we had a patient who lived here in Los Angeles, and he went to a local hospital because his wife had found him unresponsive at home. He was taken to the emergency room. He was found to have small bilateral subdural hematomas. Of course, the doctors initially thought that that was the reason he was comatose. But then a very smart neurosurgeon said, why would he have bilateral subdural hematomas? There's no trauma. He's not on blood thinners. So he looked at the CT scan and he saw that not only were there subdural hematomas, the patient also had sagging of the brain, right? So the brain was falling down into the spinal canal, basically. They tried an epidural blood patch, which is sort of the first line treatment for coma from a CSF leak. That was not successful. He did notice that in spite of the subdural hematomas, he was allowed to place the patient with the head of the bed at 0 degrees or even Trendelenburg, and then the patient would wake up a little bit. The patient was sent here to the hospital I work at. We saw that the patient had a small leak in his neck. We injected fibrin glue, and the patient woke up from his coma. So that was the first time that I saw a patient who woke up just from an injection of glue. So that was quite remarkable. And the other thing you mentioned is frontotemporal dementia. So as you know, there are different types of frontotemporal dementia. We're talking about the behavioral variant type, which is associated with really devastating problems with social interactions, with personality. These are people who are in their 40s, 50s, 60s. They're in a nursing home. They're in jail because they've been accused of sexual assault. And when you look at the brain MRI on these patients, you see an inordinate amount of brain sagging. And if you're lucky enough to find the location of the spinal fluid leak, these patients can get back to a completely normal life, even if they've been suffering with this for years or even decades. I think that's also a very important part of SIH is that the symptoms are completely reversible. Maybe not within a few hours. It can take days, weeks, months even, but it should be completely reversible.
And what does Valsalva-induced headache tell you? How important do you think it is in differentiating the type of leak or the cause of the low pressure, for example, venous fistula?
Yeah, it's interesting that you can get Valsalva-induced headaches from high pressure, right? So patients with a brain tumor commonly have that. You can get it with low pressure. We've known about that. Of course, you also can get it with other diseases like a Chiari malformation. But it seems to be, as far as the different types of leaks is concerned, it seems to be more common with these CSF venous fistulas compared to other types of leaks. And then those mainly are the types of leaks that are caused by tears of the dura.
And then MRI of the brain with and without contrast is a really great tool. Sometimes for some patients it's completely normal, and sometimes it's a sensitivity of the read. But how common is it to have completely normal MRI in the setting of SIH?
Yeah, we don't really know because a lot of patients probably have a normal brain MRI and are then dismissed by their doctor as possibly having a spinal fluid leak. So we don't really know what the denominator is. But we do know that of all the patients with proven spinal fluid leaks, about 20% will have always had a normal brain MRI. But those figures are really only true for people who have a CT myelogram or an MRI scan of the spine that shows that there's spinal fluid outside of the dura, proving that there's a leak. So if you have a patient who you suspect of having a spinal fluid leak, first thing to do is a brain MRI, preferably with contrast. Although you can probably see meningeal thickening, which is the same thing as meningeal enhancement. You can also see that on a non-contrast MRI scan, particularly a FLAIR image. So there are some centers where they no longer give gadolinium for the brain MRI, for the workup for SIH. But then if the brain MRI is normal, you really should go to a spine study to see if there's any extradural spinal fluid. Now, of course, you mentioned earlier the type of leak that was only discovered about 10 years ago, which is this CSF venous fistula, which is really a remarkable point of progress in the whole field of CSF leaks, because prior to the discovery of the fistula, we had no idea in about a third, maybe even half of patients who have SIH what the cause was. But nobody has really looked at how common the CSF venous fistulas are in patients who are suspected of having a leak because they have orthostatic headaches, but they have a normal brain MRI and they have no spinal fluid outside of the dural sac. We did publish a paper a couple of years ago where we looked at 60 patients in that scenario, so 60 patients with orthostatic headaches, a normal brain MRI, and a normal spine study. And out of those 60, we were able to find one of these fistulas in 6 of those patients. So that's about 10%. We recently showed at our meeting, our last CSF leak meeting just a few weeks ago, on a follow-up study of 93 patients, that it's still about 10-15% who have a fistula. There really is no radiographic finding that we have discovered so far that can predict whether or not somebody has a fistula. And it really depends on how good the referring neurologist is.
Let's move on to the burn score. How useful is that in helping to evaluate patients?
I believe that the burn score is sort of a two-edged sword. I think it's very helpful for centers that don't see a lot of patients with spinal fluid leaks. I think it's useful for that. I think it's useful for different centers to talk about patients, so there's a certain clarity of the reads of the brain MRI. So we talk about similar situations, similar criteria. The other side of the equation, however, is that the measurements sometimes are done by doctors who don't really see a lot of brain MRIs, and they measure it incorrectly. So I see a lot of patients who are sent to me by doctors who say, oh, if you look at these burn criteria, this patient must have a spinal fluid leak. But it's actually a completely normal brain MRI.
You mentioned spinal imaging. If the MRI of the brain comes back normal, or even if it's obviously abnormal, that the next step is a spinal image. So just walk us through your process in ordering these tests and approaching patients to localize the CSF leak.
Well, it's like this. I think it's really important to realize that in order to treat a spinal fluid leak, you do not need to localize it. I think it's much more important to try to treat the patient expeditiously, not only because that's better for the individual, but there's also some evidence that if you treat leaks early on, the outcome is going to be much better. So if a neurologist has a patient with spontaneous intracranial hypotension, just based on a brain MRI, you can make an argument not even to get any spine imaging and just to go ahead and do epidural blood patching. At least if this is somebody you see in the early stages of SIH, right, the first few weeks or months. I think if somebody's had it for many years, then you probably should image the spine because obviously something is going on that allows this leak to persist. But I think you really need to make an effort to treat the patient expeditiously. Now, like we talked before, there's really no good indication for doing a regular CT myelogram because this MRI myelogram that we talked about is at least as good as a regular CT myelogram. So we order this heavily T2 weighted MRI scan. There are a couple of downsides to that test. Number one is it's a very lengthy test. It takes an hour and a half. So that's a very long MRI scan. A lot of MRI centers are not equipped to deal with a test that takes that long. So sometimes it's difficult to order it for a physician. So, you have to talk to your favorite neuroradiology place. The other downside is that it's not performed in a lot of places. But you have to realize it has nothing to do with the MRI machine itself. It's all software. So you just have to reach out to a center where they do it. And we get a lot of those requests essentially every week on how we do these MRI myelograms. It's basically all based on software. You don't need to get a special MRI scanner for it. So we get this MRI myelogram. If the MRI myelogram shows that there's spinal fluid outside of the dural sac, then you have confirmed that there's a spinal fluid leak. Depending on how long the leak has been going on, you can either go ahead and do epidural blood patching, or if you want to localize the leak, then you would have to do some more specialized imaging. We do a test that's called a digital subtraction myelogram, which is just like a digital subtraction angiogram. It's actually performed in the angiogram suite. We've been doing that since 2009. I think we've done about 3,000 of those tests. It's a very time-consuming test. So even here, we usually don't do more than 3 or 4 of those a day, just because it takes a lot of time to do it perfectly. But it's an exquisite test that can show you 90% of the time exactly not only what type of leak it is, but also the location of the leak. There are other centers that use different imaging, like a dynamic CT myelogram, which also is time-consuming, but you don't need the equipment that you need to do the digital subtraction myelogram.
And do you sometimes order based on whether you suspect a fast versus slow leak?
Yeah, so the digital subtraction myelogram is really good for fast leaks, meaning a leak that will show itself within a few seconds or a minute, maybe 2 minutes. But it's not so good for very slow leaks. Now, most leaks are pretty fast, so you catch the vast majority of them. But if it's a slower leak, then a dynamic CT myelogram is better. Or then you can even do a regular CT myelogram with delayed CT scans.
Great. And then how often are you, because I've read that you've done some intrathecal saline studies, so how often are you using those to estimate the craniospinal elastance?
We've been doing intrathecal saline infusions for many, many years. In the beginning, we did it to confirm the diagnosis of a spinal fluid leak. So if we had a patient who we thought had a leak, but we didn't see it on the scan, we would do intrathecal saline and then do a CT myelogram. Now, with the newer techniques, that's not really necessary anymore. I usually use the intrathecal saline to see if somebody gets better when you replenish their spinal fluid. So if it's an individual where everything is normal, meaning MRI, myelogram, opening pressure, but they have orthostatic headaches and there is no curative treatment yet, right? Blood patches haven't helped, et cetera, then I sometimes do intrathecal saline to see if a patient would improve. And that can be very dramatic where people say, oh, I feel totally reborn. And there will be a patient who, when I see him in the morning on rounds, will be crying because they're not any better with the intrathecal saline. And the patient was really convinced that they had a spinal fluid leak. Elastance is a sort of a technique where there's a possibility of predicting the likelihood of a spinal fluid leak, but I don't believe it is that reliable.
And when do you suspect a patient may have a low CSF volume? So you gave a case of where the leak wasn't identified, but there's clear orthostatic headache in response to intrathecal saline.
Yeah, we think that really the underlying problem with SIH is that there's not enough spinal fluid volume in the spine, right? So first of all, people who have CSF rhinorrhea, right, who leak spinal fluid from their nose, those people never get SIH. There's never been a single case reported of somebody with CSF rhinorrhea as the cause of SIH. So 99.9% of the time, the leak will have to be somewhere in the spine. Maybe 1 in 1,000 people will have a leak at the very lower skull base in the posterior fossa that could give you SIH, but that's super rare. So there are some patients where we never discover their leak, even though we know they must have a leak. For example, a lot of these patients with behavioral variant frontotemporal dementia have a really hard time getting their leak identified. So in those people, we think that maybe there's a different reason for the loss of spinal fluid from their spine. And what that reason is, I don't know. I don't think it's inadequate production of spinal fluid, which is what people thought before myelography became available. Physicians thought, oh, the reason for this must be that a body doesn't produce enough spinal fluid. Now, number one, we cannot measure production of spinal fluid. Number two, spinal fluid really is produced in the brain, and I think it's unlikely that if you don't produce enough spinal fluid, it would only show up in the spine, but not intracranially. So maybe there's a mechanism, we don't know if this mechanism exists or not. Maybe there's a mechanism that causes rapid and extra absorption of spinal fluid just from the spinal compartment.
Yeah, that's interesting. So I'm giving you all the tough cases here. So, there are patients that have multiple spinal diverticula. And as you mentioned, get the epidural blood patch, you may have to repeat that. But at some point, you have to think about the site of the leak. So how do you approach patients that have potentially multiple sources of a CSF leak, especially with your surgical mind?
Sure. So before we discovered the CSF venous fistulas, that was a very common dilemma, right? So you have a patient, they must have a leak. They have multiple diverticula. Now that we know about CSF venous fistulas, you really need to try to figure out where the CSF venous fistula is, right? So if you have a patient with SIH, multiple diverticula, only reason that could cause SIH if one of those multiple diverticula, sometimes more than one, is associated with a CSF venous fistula. So if that's the situation, you have to do one of these specialized tests looking for a CSF venous fistula. Now, of course, there's no test that's perfect, so we still have some patients where we decide what can we do to try to localize among the different diverticula which one is the culprit. So in those situations, we do directed glue injections. So we'll just inject one cyst at a time and see what will produce a positive result. And then hopefully the glue will last forever. But of course, the glue dissolves over a few weeks, so that's not always the case. So if you are able to localize the leak by doing very directed patching with glue, then you can go ahead and fix that with surgery.
What's the most amount of patching you've done in one patient?
Well,
I guess we could talk about individual divertical and then, your approach to kind of try and identify.
yeah, so the largest volume epidural blood patch we've ever done was 135 milliliters. Of course, you can only do that in somebody who has a very extensive leak because that means that your epidural space must be very capacious. Very few people are able to accommodate 135 milliliters of blood. Uh, if you ask what's the largest number of patches, I once operated on somebody who'd had 75 epidural blood patches done.
How many of the trial and error of the diverticula?
The largest number of diverticula that we have probed with needle was, I think, 17.
Wow, that's a lot. And so let's move on to epidural blood patch because, for most patients, that's really the best way to try and treat. There's obviously some debate to how they work. How do you think they work?
Well, I think the immediate effect of an epidural blood patch is just that you introduce a hematoma in the spinal canal, and just by the mass effect of that hematoma, the pressure will increase intrathecally. That's the early effect. I think the delayed effect of a blood patch is either because it actually can go to where there's a dural tear and it can close the dural tear. So I think that also happens. And then I think there's also more of a delayed effect because the blood around the dura will become scar tissue and will prevent any leak from going out into the soft tissues. So it might still leak out to some degree, but then it's no longer able to go out into the muscle, pelvis, things like that.
And I read that you were part of a review paper and they asked several questions and pulled the literature. So, thoughts between high versus low volume and then targeted versus non targeted epidural blood patches.
Yeah, as you know, there hasn't been a single randomized controlled trial for blood patching. It hasn't even been tried versus placebo. So we have very incomplete evidence whether or not that makes any difference. But all in all, if you look at different studies, it looks like patients are treated with higher volume, that there's a higher likelihood of curing them from their blood patch. But again, that has not been proven at all. Same with directed versus indirected or undirected blood patching. Some people call that blind patching, which of course doesn't make any sense. Same situation. We don't really know what works better. I mean, we all think that a directed blood patch works better, but there's no evidence for that. We usually do glue, right? So for glue, you have to have a target. So if we do targeted percutaneous procedures, we usually use glue rather than blood.
And what are the best predictors for some of the surgical interventions, as you mentioned, the fibrin glue or the gel foam?
Well, gel foam is something that we use extensively in the operating room. It's really a hemostatic agent. It doesn't really fix a spinal fluid leak. We use fibrin glue a lot during surgery as well, not the type of fibrin glue situation where you can become allergic to it, because that only happens when you accidentally introduce it intravascularly. So the fibrin glue that we use in surgery, we just lay over the dura or over the tear in the dura.
And if you had a number of cases, and if you look back, what features of individual patient cases are most likely to respond?
Well, there's not a really good correlation between the extent of a leak and the severity of the symptoms. There is a correlation between, let's say, the extent of the tear, if we're talking about a dural tear, and the outcome of surgery or other type of procedures. Luckily, the tears that cause spinal fluid leaks are usually just 4 or 5 millimeters. So with surgery, that's pretty straightforward to fix, right? Either with sutures, or you can use artificial dura, you can use a muscle graft, or even just a hemostatic agent. So if the tear is much larger than that, right, I've seen it up to about 20 millimeters, then it becomes more challenging to repair.
And I assume maybe patients that have certain connective tissue disorders, that they may be patients that might return.
Yes, we do think that many patients who have a spontaneous leak must have an underlying connective tissue disorder. And those patients probably are at higher risk of developing a spinal fluid leak in the future. But that risk, right, so the risk of a recurrent leak is actually fairly small. It's maybe 1% per year, somewhere around there. At our last spinal fluid leak meeting in Hawaii, Cassie Parks, who's a MD PhD student at Hopkins, presented some very interesting and exciting research where we have found that about 20% of patients who have a spinal fluid leak have an underlying mutation in a gene called the fibrillin-2 gene. And we're working on trying to figure out a model where we can hopefully in the future prevent these leaks from happening.
Oh, that would be great. I mean, that seems like a real breakthrough.
It is a real breakthrough.
Well, congratulations on all your work. This is an area that we don't really touch on enough. And thank you so much for being on the podcast.
Thank you, Tesha.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes, or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.